Thanks, Mark. So I don't want to disappoint anyone, but we're not going to really dance. We will do the tag team, but we're not going to dance. This is an ambitious enterprise we're going to undertake here. We're going to try to talk a little bit about ADHD, but most importantly, how we collaborate, and hopefully we have some cases that can illustrate just a few examples of how this can be done. We'll talk a little bit about the general approach to treatment, how we want to start and finish, and then we have some selected cases to show referral patterns and what the decision-making process is for referring to specialists, and also what the decision-making process is for maintaining these treatment cases in primary care. Talk a little bit about our different roles. And to begin, we don't have any fancy technology, so I'm just going to ask for a show of hands. We'll do it the old-fashioned way. To whom do you refer patients for consultation regarding ADHD? So don't be shy. I'll just go through the letters, one at a time. A, developmental pediatrician. Raise your hands. Okay, a few. B, child psychiatrist. A few more. Child neurologist. C. Cannot refer because no one's available. D. All right, so we're kind of, okay. That resonates, I think. So, a few different choices. I think, certainly psychiatry, developmental pediatrics up there, but it is a challenge. So clearly, some sort of collaborative management approach is necessary, and maybe we can help enlighten that a little bit. Okay, another question for you. So, what percentage of patients referred to a specialist come back to you within 6 months? So, you referred them, specialists do their thing, they come back to you within 6 months. How many are like that? A, less than 25%. Okay, so some pretty few. 26 to 50%. B. All right, 51 to 75%. C. Over 75%. Okay, so most people are coming back, although there's quite a bit of variability here too. Well, to begin, let's go through some of the steps that we want to do just for treatment of ADHD, and then we'll talk about who does these steps, what stage referral may occur, and how we approach this from the perspectives of different specialties and from primary care. So step one, confirm the diagnosis. These are all things that you do. You contact other informants, caregivers, extended family. You want to have different points of view about how the child is doing. It's always good to have examples of schoolwork, report cards, teacher comments, rating scales from teachers. The best and most important strategy is to have a couple of different rating scales at different times of day, morning, afternoon. There can be a big difference, and you will get more information if you have different types of assessments reflecting different times of day. Second thing, is the family ready for some kind of treatment for ADHD? Even if it's medicines or not medicines, where are they in understanding the diagnosis and the illness and the process? For our population downtown, it's often a good idea to at least empower them to be somewhat proactive. A lot of folks may not contact the teacher or have a conversation with the teacher about behavior problems. It's more of a reactive situation. It's good for people to be proactive. If you give parents an information gathering task of some kind, say, I want the school counselor to complete this rating scale, or have a teacher fill out this rating scale for math class. Then, when they come back, you can at least know a couple of things. Regardless of what's on the rating scale, you have engaged them, and they have engaged with the teachers, and sometimes there's a lot of value in just doing that. Suitability for medication. Are they ready? Have you tried other treatment strategies? Do they understand the risks and benefits? Have other things been attempted and deemed ineffective? And then, of course, we talk about, a medication trial. Expectations, targets, side effects. Always good to start with clear target symptoms. We want to be realistic about what medicine can and cannot do. Start with a low dose. If well tolerated but limited efficacy, go ahead and increase it sooner rather than later. So these are just kind of the nuts and bolts. We usually have people come back with some frequency, often within a month, to assess the initial response, and then follow up at least quarterly for the first 6 months of treatment. We'll cover this a little bit more later because there's a lot of variability in how people do follow-up. There are many right answers for all of this, and this is part of what we want to do, is have all three of us up here discussing follow-up strategies and what makes sense for everyone. Okay, just for breadth purposes, and to be complete, it's very hard to give a lecture about ADHD without at least seeing what the world of treatment, for medication treatment anyway, is. Lots of different stimulant medicines, lots of different non-stimulants. I'll just add that this is one of the best researched conditions in all of pediatrics. There are over 200 controlled studies of stimulant medicines. This is something we know. We have much data about it. We know the outcomes. We know a lot of the side effects that are possible. And all of these medicines for different patient populations work very well. So, DL-methylphenidate, D-methylphenidate, you can see that. Non-stimulants, a few more available now too. A lot of what we do is combinations. A lot of what we do is timing through the day. They differ in onset, duration. Won't get into those details because our purpose here is how do we actually deal with the situation in the office and what kind of triggers do we have for referral. So, all roads begin with primary care. So I'll ask Ellie Hamburger to come up and begin our case discussions.
Hi again, everyone. So I'm going to walk through a couple of cases and just reflecting now on the steps that Jay just went through. Confirming the diagnosis, just to review, assessing family resources and readiness, assessing suitability for medication, discussing meds, and planning follow-up and medication refills. Probably with different patients, we as primary care providers do all or some of these steps in our primary care practices. So let's take a look at a first case. 7-year-old boy comes into the office, referred from school, because he's not completing classroom work, talking out of turn. The teacher constantly has to redirect him. The history going back goes back to toddlerhood, so you find that it's consistent with ADHD, and you provide the mom with some Vanderbilt scales, which she takes and brings back to you. How many people here use Vanderbilts in their office? So his Vanderbilt, part of it, confirms the diagnosis. This is just the top of the first part of the Vanderbilt scale that shows him to be inattentive. You can see with the high marks in the 3s and 2s, he qualifies with more than 6 out of the first 9 as being inattentive. So, a question for all of you at this point. Would you refer the patient before obtaining additional rating scales at this point? Would anybody refer at this point? Okay. And how about, okay, so both of those questions, refer before obtaining the rating scales was the first question really, and then referring at this point when you have the rating scales. So most of you, anybody here would refer at this point with these rating scales? Okay, so most people are comfortable at this point managing the patient on their own. So I won't belabor this since most of you are very familiar with the Vanderbilt forms, but they're downloadable on the internet. And in this case, this patient, we selected on extended release methylphenidate and identified some target behaviors with the mom in the office that we were going to follow, and asked her to phone back in a week. We reviewed the side effects. There weren't any when she called back, but she really wasn't seeing any benefit to the low dose that we started on. So we increased the dose, and then a week later followed up again, and he had a good response, according to her. So just show of hands again. How often would you schedule follow-up appointments for this patient? Every 2 months? Okay, a couple people. Every 4 months? Okay, a few more. Every 6 months? Once a year? People follow up more frequently? Okay, sorry, I didn't have that option there. 3 months? Can we see show of hands for 3 months? Okay. So we're going to go a little bit more into the whole follow-up issue because it's a thorny one, I think, for all of us in terms of following these kids. But let's go on to a second case. This is an 8-year-old boy again, referred from school for reading problems and disruptive behavior, especially during self-directed reading times. And on questioning, you note that he's very popular with his peers. He has a successful social life, no disruptive behavior in any other setting, and really no past history of having had disruptive behavior or problems with staying on task or attention in prior years. So your suspicion here is that ADHD is unlikely given the lack of symptoms in multiple settings, although we know that sometimes things can get underreported in other settings. But the report, when you ask more closely, is that during reading assignments in particular, the disruptive behavior emerges. And so your suspicion is getting this history that he has a learning disability. But just to check in with you again, what would your next step be at this point? Refer to a developmental pediatrician? Okay. Referral to a psychiatrist? Suggest further testing at school? Okay. Or refer to a psychologist? Okay, a few people. Sorry? Okay, or an educational diagnostician would be another possibility. So in this case, we're going to bring up our developmental pediatrician, and she's going to take over from here.
Hi, I'm Jacquelyn Calbert. I'm a neurodevelopmental disabilities pediatrician. And any of my medical school friends would pass out. They found out I went into neurodevelopmental pediatrics because I was on my way to become either an emergency medicine specialist or intensive care physician. But I realized as a resident, the one thing that scared me more than anything is when a child came to me and had school problems, like, oh my gosh, school problems. Why can't it be asthma or seizures? I knew what to do with those. And I'm sure, like most of you, when you see a child who may or may not have attention deficit hyperactivity disorder with school problems, you're thinking, oh my gosh, it's going to take more than 15 minutes. Okay, so the nice thing about sending these children to a developmental pediatrician, we do get a little bit more time. Not as much time as I would like, but we do get a little more time because probably the most important part is the history. And that history involves the personal history of the child and what you want to get into besides their perinatal history, their past medical history, and of course the chief complaint. You want to then go into some of the school history, like what's your best subject, what's your worst subject. And then you want to find out what sort of school attendance pattern. I started hearing about children who they start off the school year just excited about going to school, and 2 or 3 months in they're sort of being dragged out of bed because they don't really want to go, and then halfway through the school year after the holiday break, you can't even get them on the bus or even get them in the car to get them to school. So those are the sort of things you want to know about. You also want to know about previous school interventions. If a child's having problems in math, what sort of interventions have been done, either at school or at home. So, and then you also want to get into the family history. You may find out that one or both parents may have also had some school problems. And we're in an interesting area because we're in an international community, and in certain countries, children may stop school in 5th grade, 6th grade, and it may or may not have anything to do with learning problems. And then again, it might, but they may have gone unrecognized. So if you send the child to me or one of my colleagues, typically we try to do our own sort of mini psychoeducational evaluation, and it's truly a mini because we only have so much time, but we generally have a little bit more time than the general pediatrician. And we're trying to look at a variety of areas to decide, does this child in fact have a specific learning disorder, or is it just ADHD and it's just more obvious in a particular setting? And sometimes it's both. It's both attention deficit hyperactivity disorder and a learning problem. But you know, what you see on the screen is just an example of some of the tests. There are many, many tests out there. Some take longer than others, so we have to select which test we'll do depending on how much time we have. But also, in addition to actually doing developmental testing, we also are looking at the child. Sometimes the child may have some sort of neurocutaneous marker that has a higher association with learning problems like neurofibromatosis. And I think those who were here for the dermatology lecture saw things like cafe au lait, which might indicate. You also saw like the port wine stain. These are sort of things we're looking for. And then if, in fact, if we were in an ideal world before my present position, I did have a somewhat of an ideal situation where I had a whole team with me and we were able to sit down together. If I thought the child needed to see a speech therapist, he or she saw a speech therapist on my staff. If I thought they needed a psychological evaluation, there was a psychologist right there. It was great. And then we would have what we call an interdisciplinary meeting to discuss the child. And it's kind of nice because you're seeing people are seeing the child from different viewpoints, and then we generally get a true 3D vision of that child. And so when you get a report back, you would often get a combined report with all of our findings, which I think the referring physicians really, really liked. Okay, so in this child's case, they were referred to a reading specialist, and that specialist could be someone at the school, a reading resource teacher, or it could be someone out in the community, perhaps someone who's at one of the learning centers like Huntington or Sylvan. Also, as far as the IEP development, the child, as most of you know, has to go through a psychoeducational evaluation that's determined by federal law. There are certain specifics that have to be met, and once the child goes through that assessment, they may or may not qualify for an IEP. And you know, as a developmentalist, I try to help the parents know what to do, how to go to the school and request an IEP. The most important thing is that they date the request, say, because then the clock starts ticking. And as I said, sometimes the learning problem may be a learning problem on its own. Sometimes it may actually be combined with attention deficit hyperactivity disorder. So these children need to be followed up. You may implement resource support and help to address the learning problem, and you may see some improvement, but still the parent and or the teacher may still feel, I'm still just not sure we're getting everything out of the child. So then we may need then do further assessment to see, in fact, is this perhaps an attention problem in addition to a learning disability. And typically the children I see in my office will have both. I do have the rare cases where it's just a learning problem or it's just ADHD, although I don't know what just ADHD means, but yes.
Okay, so a third case that we wanted to bring to discuss, a 5-year-old girl who's referred in for academic delay and running out of the classroom and into the hallways. In your office, you note that she definitely has some social difficulties. She doesn't have any friends. She prefers playing alone. You note that she has some limited, intense interests. And suspecting that she needs help, you refer her to a developmental pediatrician. Again, so we'll bring Jackie back up again to discuss this case.
I'm back. Okay, so I think most of you see the news. All you hear in the news is autism or autism spectrum disorder. To be perfectly honest, I don't know what autism spectrum disorder is, and all the families who come to see me, I get on my soapbox about this because autism spectrum has become so broad. I mean, I saw, just this week, I saw a little girl who came in with a diagnosis of autism, and she comes in, she does look a little nervous, a little shy, and then after a while, after she realizes that I don't have a needle hidden behind my back or under my seat cushion, I'm actually a fairly nice person, she became very comfortable, started doing drawings, was showing the drawings to me, and like, what do you think about this? Oh, look, I drew a man. Look, he has long hair. My daddy doesn't have long hair. I'm like, oh, great, oh, that's lovely. And it was a very lovely child. She was interested in the conversation I was having with parents. In fact, she would interrupt the conversation multiple occasions. Parents said, oh, she's not normally like this. She's usually kind of shy. But she'd taken over by the end of the appointment. She was running things. So I'm like, perhaps not autism. So this is one of the things that, as most of you know, there's a panel who's looking at this now and trying to determine what are some real guidelines that we can use to talk about autism or autism spectrum. And what you see on the screen now is how autistic, the classic autistic disorder, how it's described. And you see there are three major components: the impaired reciprocal social interaction, impaired communication and imagination, and restricted repertoire. And you see it has to be at least two from the social, at least one from a communication, and one from the restricted repertoire, and you have to have at least 6. So, if you meet that criteria, then clearly the child meets the diagnosis of autistic disorder. And as you know, that falls under the big heading of pervasive developmental disorders. Now, when DSM-5 comes out, it's not exactly clear how this is going to work out. But, we know that Rett syndrome is probably coming out. That won't be one of the 5. But, pervasive developmental disorder includes autism, Asperger syndrome, PDD-NOS, and Rett syndrome in DSM-4. That, as I said, is probably coming out, and then childhood disintegrative disorder. As we know, Dr. Connor, who was a KA-NNER, who was a child psychiatrist, was the first person to discuss autism or autistic aloneness or autistic disorders of affective contact. In this child that we see who's running through the hallway, who doesn't have friends, some of the things that would come under autism would be the failure to develop peer relationships appropriate for developmental level, restricted, repetitive, and stereotype patterns of behavior, interests, and activities. These are sort of questions you can ask. Does the child, sort of engage in certain behaviors? And usually I say, does your child have any unusual behaviors or behaviors you or your significant other find as sort of odd or things that bother you? And I sort of let the parents describe. I don't try to put words in their mouth. I let them tell me what they find. And then there's that persistent preoccupation with parts of objects, like the kid who likes to spin the tires on a train. They don't really push the train around going choo choo, choo choo. They're just spinning the tires on the train. That is something that's a little unusual. So those are sort of things that I would ask about with the parents. And you also have to think about differential diagnosis. Does the child actually have cognitive impairment or intellectual impairment? And oftentimes that's missing. When a parent comes to see me and says, oh, my child has autistic disorder, and I see the child has moderate to severe intellectual impairment, I mean, that's important, to know, because and especially like in the schools, a lot of times children can't get services unless they're categorized under autism or autistic disorders. And, it's unfortunate because the child who is, to say, the high-functioning child with autism is very different than the child with the more common type of autistic disorder who has more mild to moderate, or mostly moderate, to even to severe cognitive impairment. Okay, so thanks.
So And what we've done so far is taken a case that looks like a pretty straightforward case of ADHD and a couple of other cases that have variations on the theme and tried to sort of point to where we might refer from primary care. And this is our fourth and last case that we want to present. We hope to allow some time for discussion and questions here at the end as well. This is a 9-year-old girl who's referred into primary care with academic difficulty and noted distractibility in class. And now she's actually protesting going to school. When you take a history on her, you discover that she, it's really not so clear when you start asking questions whether she's always seemed distractible or not. There doesn't seem to be any precipitating event that's led to her protesting going to school. And so you provide a Vanderbilt to the parents to take, and they bring it back. And this is, since so many of you are familiar with the Vanderbilt, you'll recognize this part of it that looks for comorbid disorders. And I don't know if you can read the items up there, but it turns out that there are a lot of positives here to her being, she's fearful, anxious, and worried. She's self-conscious or easily embarrassed, afraid to try new things, feels worthless or inferior, blames herself for problems and feels guilty. And she's really having some issues with performance in school. So this, again, doesn't really seem to like a straightforward case of someone who has attention problems, but perhaps some comorbid disorder. So she is referred to psychiatry.
And of course, all the referrals occur just this easily. You know, we just get right up and come in. So this case, a little bit more complex. Makes sense to refer to psychiatry. The clues were on the Vanderbilt, certainly with the questions about anxiety, feeling guilty about things. Doesn't necessarily prove ADHD, but it certainly has you alert to the fact that there might be something more than ADHD going on. So, you know, we can assess this patient, we do the evaluation, we certainly go into more mood, anxiety, depression, those types of things. We want to assess their mood states, how they handle stresses and anxieties, what the irritability level is, how they respond to limits, all these things that can reflect affect regulation and flow of thought to some degree. Just for the exercise here, we'd said, okay, this patient seems to have ADHD. You know, we know at least that seems to be present. The distractibility is significant, and you can go through all the criteria and say, sure, it happened early on, happens in multiple settings. So we said, okay, great. We're going to start extended release methylphenidate. 2 return visits in order to establish an optimal dosage. And I will kind of digress a little bit with this. I tend to want to see people early on in treatment so that I see what they look like with the medicine. Now that means we have to see them during the day, not at 5, 6 o'clock when the medicine has worn off. So we see them during the day. We can at least tell if they're moody, if they have flat affect, if they're ticking. We can see that. We can know right away if we're going the right direction or not. And then maybe another return visit just to establish optimal dosage. You can certainly go ahead and increase the dosage so long as it is well tolerated. So, did that. The other trick here, which I'm sure most of you have done many times, contact with the school counselor. There is some difficulty, some anxiety about arriving in school. Let's develop an arrival routine. For this child, the arrival routine involved going to the counselor's office. The counselor would greet her. The counselor, they could hang out, adjust for a few minutes, maybe 5 minutes, and then the counselor could bring her up to class. And that kind of thing, very easy. Eventually, you could have other people serving in that arrival routine, maybe a teacher's aide or a support staff or a paraeducator, other people that can also serve in that role. So, thought, okay, we established ADHD treatment, got an optimal dosage, dealt with the mild anxiety a little bit, so we'll refer back to primary care.
Okie doke. So she's back seeing me. And I see her back for a follow-up visit. Of course, I've gotten a detailed letter from Jay explaining how he arrived at the diagnosis and what the treatment plan is. And she comes back to see me in 3 months, and she's making good progress with her report cards, and we repeat the Vanderbilts, and things are looking good. 6 months later, she comes back, and she's not doing so well. And the anxiety behaviors that we heard about before have really escalated quite a bit. Again, no clear precipitant for this. We dig a little further into family history and find, indeed, there has been a family history, maybe of ADD, but also of anxiety disorder in the mom and 2 of her sisters. So we refer back to psychiatry for further help.
Okay, so the key thing here is that follow-up occurred every 3 months, and that was a way to catch these symptoms before they developed even further. And we can talk about that, and I hope we have time. We should have time for a discussion about just the nuts and bolts of follow-up and how often people come back for return visits. It's always a question that comes up. Because this follow-up occurred every 3 months, we could identify anxiety that seemed to be persistent. We tried to address it early, and these kids are moving targets sometimes. So sometimes the anxiety can build and develop, and then you need to pay more attention to it. So I could see her again and said, you know what, the ADHD is okay. It's not a problem of distractibility. The medicines are well tolerated. We've continued them. But it does seem like there's a generalized anxiety disorder. So this patient remained with psychiatry. We had a 6-week course of psychotherapy, focus on relaxation techniques. There's nothing too fancy about doing things like this, and you can learn some of these things to do in your office or even explain. One of the easiest tricks to do for relaxation, just this. Put your hands behind your head. What does that do? Changes the position of your diaphragm so you can actually get about 10% more oxygen capacity or lung capacity. Hey, quick and easy, right? Most people want to do something. So if you tell them that they can do this, then it can help. There are many other relaxation techniques. We talk about progressive muscle contraction and then relaxation. You can talk about imagery. You can talk about other things to distract your attention from whatever is making you anxious. So that kind of thing we can do. And then we resume the arrival routine. And for a lot of kids with panic disorder also, or panic attacks, you can do something called a flash pass. So the understanding occurs from the counselor and from other teachers in whatever classes they happen to be going to, that they have a special card or a special pass that they can just hold up if they need to get out of the room. You know, rather than sit there and become gradually more and more anxious and nervous and have a full-blown panic attack. Flash pass allows them just to walk out. Usually you go to the counselor's office or sometimes the main office, find somebody to talk to so you can sit and relax and then maybe go back in. It can be very effective, and it's very simple to do. You don't always have to use an SSRI. The data is not terrific in prepubertal kids, certainly. We wanted to at least try a course of psychotherapy. And then, given that there was some improvement with these other interventions, we did not use an SSRI. And then referred back to primary care. So, those are the 4 cases, and I'll go through some of the details about a model and eventually open it up for discussion. What we've seen then is one case 1, pretty straightforward ADHD. Manage it, diagnose it, increase the dose, do 1 step, keep that one. Case 2, not particularly straightforward case of ADHD, but seem to have some real learning issues. Refer to a developmental pediatrician. They can do some in-office techniques, spend more time, identify learning disability. Developmental pediatrician can help architect the IEP a little bit and refer to a reading specialist, clarify those issues. 3rd case, we have a little bit more complex, maybe it's a developmental disorder, pervasive developmental disorder, autism spectrum perhaps. Refer to the developmental pediatrician. The developmental pediatrician actually maintains follow-up with that case. And then this recent case, sort of a hybrid. And To the degree that we can collaborate and have a pretty ready referral scheme, you can see that there are some issues. Once they become stabilized, great, back to primary care management. If there's any type of relapse, so long as you're seeing them more than every year, maybe even more than every 6 months, then you can catch it, and you don't have to have specialists following all these cases. But if we can have a ready referral stream to identify these problems as they occur, then you can go back and forth, primary care and specialists. So this is a work in progress. It'd be nice to have specific guidelines for referral back to primary care or contact with specialists at set intervals. These things don't necessarily exist right now, but if we do make some efforts for this, we can identify some red flags for seeking consultation. And the key thing is communication, being able to, we can't always pick up the phone and talk to each other. We can sometimes, but when we have a large number of patients, it's hard to do that. It's better if we have some sort of document that we can keep in the record so you can refer back and say, oh yeah, this person saw the specialist. What would that document look like? How would the communication be effective? This is one example. You've seen this earlier today. Dr. Hamburger presented this. Co-Management Toolkit. It's a great idea. It's terrific. This is just for migraine headaches. We can tailor-make this for ADHD, for other kinds of conditions. Treatment plan. If improved, continue. What are we treating with? What kind of follow-up is necessary? If not, improved. So you can imagine that these kind of things could be developed. Just one example. There are many ways to do this correctly, but having a document like this for referral or contact with specialists could be very handy. So hopefully we'll be able to work on this a little bit more. Now, for completeness' sake, and I'll just have sort of a few more minutes of this, and then I'll bring my colleagues up here to talk a little bit more about the collaborative model. There are a lot of different reasons that you might want to very quickly refer to a specialist. Certainly, history of epilepsy, history of Tourette's syndrome, then it becomes not as straightforward a case. You want to have some consultant involved in making sure that the medication choices and those decisions are okay. You could refer to a pediatric neurologist for either of those situations. There are a lot of different controversies, and just because this is an ADHD talk, we want to discuss this just a little bit. Growth retardation is still out there. People are still concerned about it. You will know, as primary care pediatricians, whether there is a problem with growth or not sooner than anybody else. Primary care physicians usually pay attention to this much more than anybody else. So you'll certainly know. The reality is that it doesn't seem to be, if it does occur with the stimulant medicine, it doesn't seem to be related to growth hormone. It doesn't seem to be related even to treatment or lack of treatment. The evidence that's out there shows that people with ADHD tend to be about an inch shorter than people without ADHD, but it is not treatment related. Now go figure. Who knows? Why is that? Maybe there's something about the sympathetic nervous system or feedback relationships or maturity, who knows? But it doesn't seem to be related to the stimulant. Now, what we've all seen, kids that don't eat are the ones who don't grow. And we certainly know that one of the main stimulant side effects, perhaps the most difficult one to deal with, is decreased appetite. And that's something that might be a reason to refer also. Abuse potential, by and large, with the time-release medicines out there now, there's not a whole lot of people abusing it. Now, there are individual cases, but most of the time, if you have a real serious abuser, they want short-acting Adderall. All right? That's your red flag. If that's the only thing that's going to work for them, okay, maybe you refer that one. Cardiac effects, that made the news recently. Just a quick word about it. Actually, a lot of the information from the initial paper in circulation was retracted. The bottom line is that there is no further risk with stimulant medicines in the general population as without stimulant medicines. If you do have some sort of structural heart defect, then sure, there's going to be a risk, but it usually doesn't have much to do with the stimulants. It has to do with a whole host of other things. And then treatment in preschool-age children, very controversial. Those are the people you probably want to refer to Dr. Calbert and make sure there's not some sort of pervasive developmental disorder going on or other types of complicated issues. Actually, I think I'm going to call my colleagues up here, and we're going to go through some of these very common questions that come up. So, Dr. Calbert, don't these kids just need discipline?
Yeah, and the tougher the better. No. Actually, that's one of the things I love the preschoolers, and typically when I talk to the parents, I wish I had more time. That's the one area where I feel I don't have enough time is to do the counseling part. I get started, but I have to try to convince the parents perhaps to take a parent behavior modification course. But I do give them some pearls. And typically what you want to do with the ADHD child is catching the child being good. In other words, the child with true ADHD really is more of an attention seeker. They want you to pay attention to them. And so I try to tell the parents to do more of a positive behavior modification. In other words, when Johnny is doing something nice, let Johnny know you saw it. Oh, you're such a good big brother. You're so nice to your little sister, or you're such a nice sister. You're so good to your big brother or your little brother. When they do things that are not particularly, not something you particularly find enjoyable or something you don't particularly care for, but it's not dangerous, it's not offensive, then try to ignore it. You know, if they're tearing up paper and just throwing it all over the floor, and as long as you don't have company coming over or your mother-in-law or something, you pretend you didn't see it, but then later on then you can say to the little Johnny or Susie, hey, help mommy clean up, or help daddy clean up, you're such a good helper or something. And then, and compliment them as, oh, you're doing such a good job. And so the hope is you try to encourage those positive behaviors and sort of wean away those more, they're sort of the neutral, what I call the neutral behaviors or annoying behaviors. I try to use the word annoying because children do get upset when you say they're annoying. Those behaviors. But if they do something that's particularly that is what we would consider offensive or dangerous, if they're going around biting, kicking, scratching, then that's when you really do need something like a timeout, because obviously you need one because you're really angry. You don't want to say or do anything that you'll regret later, and you want the child to get a chance to cool off. So that's when you say, hey, that's a timeout. You can do the 1, 2, 3 magic. Obviously if someone bites them, you don't give them 2 chances to bite. Okay, that's the second bite you've done on Johnny. You get to that 3rd bite, you're in timeout. No, it's like, okay, that's it, timeout, or, and I tell parents it's easy at home because you have places that, this is your timeout corner, your timeout chair, and I let them know you don't stand there and talk to the parents, to the child. No, Johnny, the reason you're in timeout right now is because blah, blah, blah. No, Johnny's in timeout, and he's he's, persona non grata, you don't see him. And then when he's out, you forgive it. For the most part, you forgive it. There's some things that are much harder to forgive, but you try to forgive him, and it's, gone away. Some things you may want to talk about later, but you've had a chance to calm down, so you're not, have your mean face, or you're not yelling or anything. But yeah, so what it comes down to is that sometimes parents truly need what I would call a formal course on behavior modification, or they can read books on how to discipline a child. And in our society now, it's more gentle discipline. It's not like in the old days when a person would just say, okay, go get me the belt, or like what my grandmother would say, go get the switch off the tree, and it better be a good one.
So they all need discipline.
They all need discipline.
Yes. Less to do with ADHD, essentially, than just in general. 1, 2, 3 Magic, Jackie mentioned, great resource. Timeouts, if timeouts don't work, it's a failure of execution. We use timeouts in the inpatient psychiatry unit. Execute them properly and they'll work well. Dr. Hamburger, I don't want Ritalin. I've heard bad things about it.
So we all get this question in our offices. Lots of times what parents are really concerned about is the second question here. Will it make kids more likely to do drugs? People are worried about addiction and more drug use. And I think most of us know the data about this and quote it to parents that kids who truly have ADHD and are on medication appropriately dosed are less likely to abuse medication than those who aren't. So that's usually our answer in regard to that. Other things that parents have heard about are the growth issues that Jay touched on already. Anybody else encounter other prickly problems with parents not wanting to use Ritalin? Anybody have things that come up in the office? One other issue is, the concern that a lot of parents have, I think, that, you're trying to make my child like everybody else, and he's special and unique, and there it's a matter of just how dysfunctional the ADHD is making the child in the classroom and at home, and pointing out also that the medication is very short-acting. So the trials that we do can be, medicine isn't in their system anymore. If it doesn't work or if there are side effects, you can stop it or move on to another medication. So I think we want to open it up to discussion.
Yes, although I was very curious because nobody had questions or problems in the office. People asked about, I said, yes, one back there, please.
When it's not used. So tell me the steps of getting a developmental pediatrician in real time.
Oh, okay, so you actually wanted, practical application, yeah.
No, I really
The question
just want
is,
to pipe.
this is all well and good, we can model different collaborative things, but, the fact is when you call somebody in the phone, then they say come back in, a year or 2 years, because that's when we have an opening. It's true. All right,
Can't
that is true.
trust you guys. That's the problem. We can't trust you to be available when you're needed.
Yes. All right, so a lack of trust. Yeah. Well, I tell you what.
I can tell you that at Children, this is an evolving picture. We are slowly trying to get more people on our team so that we can see our children, the children that we're consulted on sooner than later. We have a nurse practitioner now part-time who's doing a medication refill clinic. That's been fantastic, which I think helps us because if she's doing some of the medication refills, then that means we can get some more other children back in, or even it may be even a follow-up child that's more problematic. We can get them. We have more appointments available to see the more problematic children.
Approach. Get a bunch of nurse practitioners and train them in developmental medicine, and that'll solve everybody's problem. It's done in every other field. Why not yours?
Actually, send them our way. Okay?
Yeah. Send them.
We don't see them. They're not coming applying for jobs with us. So send them our way. Let me, we have a few more questions, so let's go right here.
Hang on one second, we'll come here. The other thing I would say to all of us here is there are not enough developmental specialists in the pipeline to see all the kids who are currently being referred. So just think about this as a math problem or an economic problem. We can try to dial in more developmental capacity and we need to do that, and I think your suggestions are good ones. I think the other thing is we need to control demand. And demand right now is highly unfiltered because in the practice world, and we all sort of laughed ahead of time, it was sort of this laughter of recognition. It's like, why can't it be a kid with asthma? Right. Why can't it be a kid, with an earache? I love seeing earache as the chief complaint. Why do we like earache as the chief complaint? Because it's fast. And we get paid almost as much as we do for spending an hour with sort of a complex kid. But the way the world is going is, we need to figure out new models that permit us to sort of manage lower acuity, more straightforward kinds of conditions in our office practices so that we can unclog some of the demand that is actually adding to 6-month waiting lists in specialty areas where there just aren't enough people in training programs to address it. And we're not going to fix the problem just by hiring more and more developmentalists. There just ain't enough. There are not enough developmentalists. There are not enough psychiatrists to meet unbridled demand. And that's in part why we're trying to have these sessions and start the dialogue with the idea that we can actually begin to change our practices over the next couple of years so it's much more collaborative and then makes some impact. And I agree, adding to capacity.
I couldn't have said it better, Mark. That's exactly right. I mean, we can have everybody in our department working 24 hours a day. We still will not meet demand. And there are still going to be people who say, you know, why can't we get in to see you? That's just the reality. Child psychiatry, developmental pediatrics, these are shortage specialties. And that's part of the impetus here for us to build a collaborative model. We need to do something, at least, so we can take care of more people.
Just wanted to add, I think that part of this, you're right, Dick, that this isn't a realistic, our little dance up here wasn't totally realistic. But I think that the issue of really communicating back and forth to each other, so that what we're finding as we start these discussions at Children's is that the specialists are seeing kids for ongoing care that really can come back to primary care. So if we can work more on the communication back and forth, so the kids who really don't need to be going back to Jay and Jackie for medication refills, and neurology too. They see tons of kids for medication refills that can really be back in our offices. I think that can really unclog the system to some extent. We should take a next question.
Yeah, let's go right here at the microphone.
So my question is actually, or maybe more of a comment, but there are a lot of times that some of these children that come, one of your statements there was, you're trying to make my child like everyone else, my child's special, and you're trying to make them like everyone else. And sometimes as a physician or a pediatrician, recognizing that the parent that brings the child in is also kind of special, and they probably have their own, sorry. Meaning they were probably undiagnosed as ADHD themselves, has a little adult ADHD going on. They're functional, and they're functional rather, and so their concern about what you want to do to their child is sometimes and this is even on a personal note where I've had to talk to people I know and their child has it, and I realize they probably have something that was undiagnosed. How, as a pediatrician, when we're talking to them about their child and their similar problems that they had as a child, but I got through it, do you address that in the adult and kind of explain to them that they probably need some care?
Oh, absolutely. Absolutely. That's, as I said, part of the history is not only the personal history of the child, but also the family history. And a lot of times I can draw that out of the parents. And in fact, I had this one little girl, I've been following her now 3 years. And the father, I kept dropping, not really subtle hints to the father, that the behaviors he denied that the child had, but the mother saw and the teachers all agreed the child had these sort of behaviors, and the father was in denial. Finally, after about 3 years, the father looks at me and says, I think I have ADHD. I'm like, I said, I won't argue with you about that.
Let's move on to right over here.
Okay. But yes, I do. I talk to parents.
You had asked about medications, and we do see a lot of patients who do have concerns. What is this? What are you going to do to my child's brain? We're going to give this medication that's going to affect his brain. How do we know it's not going to affect them 20 years down, 30 years down? So I was wondering if you could comment on any long-term studies.
Sure. We have the MTA study, which was initially published in the late 90s. There continues to be follow-up. Now, 10, 12, 15 years. We don't see any, certainly no lingering neurologic terribleness that's going on. The other thing that I tell people is that this is a very widely studied medicine, and Ritalin came on the market in 1955. This is, it has proven the test of time. Real quick, let's go here. I'm going to try to get everybody in if we can. We only have a few minutes.
I have a twofold question about comorbid kids who have anxiety and or depression and ADHD. Number one, do you think the stimulants aggravate the anxiety or precipitate it? And two, if you're going to start treating with the drug, does it make a difference if you treat for the anxiety depression first or the ADHD first?
Yeah, very good question. And that was one thing about the MTA study. A lot of these kids did have anxiety, but it wasn't measured that well at baseline. Many of them actually improved. It's sort of a chicken and egg phenomenon. Are they anxious because they can't pay attention? They know they're in trouble in school, so you treat the ADHD, that the anxiety gets better? Or did they come to the table with anxiety to begin with? The stimulants tend not to exacerbate anxiety, but here, the rule of thumb is start with a low dose. If anything isn't quite right, you're going to see it early versus late. So it's a tough question, tough problem, but I tend to think they're comorbid often because kids, will get nervous because they know they're in trouble in school. Let's go here.
Yeah, just a quick comment about timeout, and I don't know how that jives into what Dr. Adler thinks and the positive discipline movement, and how about when you punish and reward, you're it's short term. It may work for a little bit, but it's not sustainable, as opposed to working with a kid to develop more intrinsic, internalizing.
Yeah. You got to save your timeouts for big problems: violence towards people, towards property, violent words. Those are the key things. I usually add things like rudeness, foul language, but that's just me. I don't like that. So for your big things, save your timeouts. It's a powerful weapon. Don't use it casually. Right here.
One of the things I disagree with your length of time for follow-up. You can't get to know the family or the kid if you see them once every 2 to 3 months. They should be shorter visits, limited goals. And 2/3 of the kids have a sleep onset disorder. You didn't address that, and that'll make their mood and anxiety disappear if they really sleep, or the parents sleep.
Absolutely, yeah. Sleep is one of these things that has to be sorted out. Sometimes mood disorder, one of your clues is a disruption with sleep. So that's true. I mean, how many people would follow somebody for every month, even for a 10-minute visit?
Sure.
All right, well, maybe. I mean, that's going to certainly defray some of the clinical load. Okay, really quickly, please, quick question.
Well, quick comment. There's a wonderful national organization, CHADD, so CHADD. I'm as we talk about collaboration, I think families want to come to their medical home.
Yeah.
My patients don't want to go to Hopkins. They don't want to go to Kennedy Krieger. They want to come home. Yeah. And so over the last decade, have gotten myself educated. There are parent-to-parent workshops that are available. You can design anything that you want through many collaborations. The schools in our school system in Baltimore, the nurses are putting on these programs called Putting on the Brakes, where they're kind of engaging the higher risk kids early in the school year. I think you've got to get a little outside this pathological model and kind of celebrate that it is kind of a disorder that, when treated, really alters one's entire potential and experience of their education from this point on.
And I just want to say, as someone who trained at Hopkins and the Kennedy Krieger, I do refer my parents to that website, chadd.org, and other websites.
So, just Maryland has a very active Annapolis. It has a Greater Baltimore division that has 5 adult and provider parent support groups. That meet monthly. So you can, parents need to, feel that they've got the support. And it's hard to get it all out there in the hour that you're together.
Yeah, and that's one of the things. I do have a lot of educational materials, and I do tell the parents this is for both children and adults who may or may not have been diagnosed with ADHD.
Muriel, can you get it done in 5 seconds?
Very quickly. I'm just concerned that with the paucity of people that are available to sometimes consult, what can we expect from the schools? Because many of us find it very frustrating that kids are not tested adequately. I know you have the 90 days or whatever it is, but for many of our children, if 15% of kids need help potentially, what are we going to expect from our schools?
Exactly, and so that's why when I see a child and I'm concerned about any sort of educational problem, I do my own mini assessment, and therefore I'm able to give parents, I'm able to tell them what they need to go back to the school and say, these are my areas of concern, and these are interventions we can do in the meantime while we're waiting for a formal evaluation through the school. So we can do interventions before we even start the testing, formal testing at school?